Consider a number that most people find difficult to believe the first time they hear it. Approximately 40% of elective surgeries performed on adults over the age of 65 result in no measurable clinical benefit, and in a meaningful proportion of those cases, the patient's condition is objectively worse at the 12-month mark than it was before the procedure. This figure does not come from fringe research. It comes from a systematic review published in the BMJ in 2020, which analyzed decades of surgical outcome data across multiple specialties. The reason this number is not discussed in most pre-surgical consultations has nothing to do with deception. It has to do with how surgical training is structured, how hospital systems measure success, and how profoundly the human mind, including the minds of skilled physicians, underestimates the difference between a body at age 40 and a body at 68. After the age of 60, the physiological response to surgical trauma changes in ways that are still being mapped by researchers. Inflammatory cascades triggered by general anesthesia behave differently in aging tissue. Wound healing slows, muscle loss during recovery accelerates. Cognitive disruption following anesthesia exposure, a condition now formally recognized as postoperative neurocognitive disorder, occurs at measurable rates in adults over 65. By the end of this presentation, you will understand exactly which 5 surgical procedures carry the most disproportionate risk-to-benefit ratio for older adults. And more importantly, you will understand precisely what the published evidence recommends as an alternative before any incision is considered. Understanding this framework is essential before examining the 5 procedures in question. It is a mismatch between when surgical evidence was gathered and the population currently receiving surgical recommendations. Most of the landmark clinical trials that established the standard of care, conducted in the 1980s and 1990s, was often under 55. Those results were then generalized to patients 20 years older, patients with different inflammatory baselines, different hormonal environments, different mitochondrial reserve capacity, and profoundly different recovery trajectories. Different mitochondrial reserve capacity and profoundly different recovery trajectories. A concept called physiological age. The SPORT trial, the Spine Patient Outcomes Research Trial, published across multiple papers in the New England Journal of Medicine between 2006 and 2013, tracked patients with degenerative spondylolisthesis for 4 years following either surgical or non-surgical intervention. Helps explain why 2 70-year-olds can have dramatically different surgical outcomes. Research published in the Journals of Gerontology in 2019 demonstrated that physiological age can differ from chronological age by as much as 15 to 20 years in adults over 65, and that physiological age is a far stronger predictor of surgical outcomes than birth year alone. Understanding this framework is essential before examining the 5 procedures in question, because the problem is not surgery itself. Surgery remains one of medicine's most powerful tools. The problem is surgical recommendations made without adequately accounting for what the aging body can and cannot recover from in a compressed clinical timeline. The first procedure on this list is performed more than 400,000 times annually in this country alone, and a landmark randomized controlled trial published just years ago has fundamentally challenged the reasoning behind most of those operations. That finding comes next. Procedure 1, elective lumbar spinal fusion for degenerative back pain. Spinal fusion is the surgical joining of 2 or more vertebrae. Using bone graft material and metal hardware, the intended result is the elimination of movement between those vertebrae, with the expectation that removing movement will remove pain. This logic is anatomically coherent, and it is also, according to the current evidence base, frequently incorrect for older adults with degenerative disc disease. The SPORT trial, the Spine Patient Outcomes Research Trial, published across multiple papers in the New England Journal of Medicine between 2006 and 2013, tracked patients with degenerative spondylolisthesis for 4 years following either surgical or non-surgical intervention. The SPORT trial, the Spine Patient Outcomes Research Trial, published across multiple papers in the New England Journal of Medicine between 2006 and 2013, tracked patients with degenerative spondylolisthesis for 4 years following either surgical or non-surgical intervention. Outcomes for spinal fusion were not statistically superior. The finding that reshaped the field to structured physical therapy combined with targeted pain management in patients without severe neurological compromise. Degenerative back pain in older adults is rarely produced by a single unstable level. Adjacent segment disease, the accelerated degeneration of vertebrae immediately above and below the fused level due to altered mechanical load distribution. The average age of participants in foundational surgical trials conducted in the 1980s and 1990s was often under 55. Those results were then generalized to patients 20 years older, patients with different inflammatory baselines, different hormonal environments, different mitochondrial reserve capacity, and profoundly different recovery trajectories, including psychological stress-induced cortisol elevation, sleep disruption, and social withdrawal, all of which have measurable effects on immune function and cardiovascular health in older adults. When a surgical recommendation is made, the following structured approach, drawn from frameworks used in geriatric surgical assessment, provides the clearest path to an evidence-informed decision. The second procedure on this list involves a cancer diagnosis. Procedure 2, radical prostatectomy for low-grade prostate cancer in men over 70. The same survival outcome with no surgery? The surgical consequences, by contrast, are not hypothetical. Active surveillance, defined as PSA monitoring every 3 to 6 months, pause for a moment on something concrete. Procedure 3, open surgical aortic valve replacement, when TAVR is available. Transcatheter aortic valve replacement, or TAVR, delivers a replacement valve via a catheter introduced through the femoral artery. The physiological advantage of TAVR in older adults is mechanistically straightforward. The appropriate question for any older adult facing an aortic valve recommendation is direct and specific. Is transcatheter replacement an option for my anatomy and risk profile? Before continuing, if this level of research precision is what has been missing from your conversations with the medical system, subscribe to the Eternal Vigor Way right now and enable notifications. Subscribe now and let us continue. Procedure 4, elective hernia repair for asymptomatic inguinal hernias in older adults. That default is no longer supported by the evidence. For adults over 70 with cardiovascular comorbidities, the anesthetic burden of hernia repair carries risks that are neither minor nor theoretical. A hernia that is not causing pain, not growing rapidly, and not impeding daily function in a 75-year-old is not a surgical emergency. What distinguishes this information from what is typically available is not the science itself. The studies cited here are published and accessible. Procedure 5, elective colon resection for recurrent uncomplicated diverticulitis. For older adults with metabolic comorbidities, type 2 diabetes, cardiovascular disease, or impaired renal function, elective colon surgery carries a risk of anastomotic leak of 3 to 8%. The critical biological distinction is between complicated and uncomplicated disease. What follows now is the single most actionable section of this entire presentation, a precise evidence-based protocol for navigating any surgical recommendation, designed specifically for adults over 60. Stay through this. The questions outlined here have the potential to change a clinical outcome. When a surgical recommendation is made, The following structured approach, drawn from frameworks used in geriatric surgical assessment, provides the clearest path to an evidence-informed decision. Within the first 48 hours of any surgical recommendation, request the specific journal citations supporting the recommendation for your age group and your precise condition. Not the general population, your age group, your Gleason score, your eGFR, your ejection fraction. A physician unable to provide this information is working from generalized training, not current evidence. Before agreeing to any elective procedure, document a minimum trial period of 8 to 12 weeks of the best available non-surgical alternative: physical therapy, dietary intervention, targeted pharmacological management, or structured monitoring. The evidence for most of the procedures discussed here shows that this conservative trial period, when genuinely implemented and tracked, produces outcomes statistically equivalent to surgery in the majority of older adults. At every surgical consultation, bring a written list containing 3 specific questions. First, what does the published literature show for patients with my age, my exact diagnosis, and my comorbidity profile, not for the general population? Second, what is the strongest available non-surgical alternative, and has it been fully implemented for the minimum recommended trial period? Third, am I a candidate for a less invasive intervention? TAVR instead of open valve surgery, laparoscopic instead of open repair? Regarding timeline of expectations under conservative management, in the first 2 weeks, measurable symptom change is unlikely. The nervous system, inflammatory mediators, and musculoskeletal structures do not reorganize in 2 weeks. In weeks 3 through 8, most patients following structured physical therapy protocols for back pain begin to report functional improvement, not pain elimination, but measurable functional gain. By month 2 onward, the majority of patients on well-designed conservative protocols have established a stable trajectory, and the decision to revisit surgical consultation becomes genuinely evidence-based rather than reflexive. A second opinion at an academic medical center with a dedicated geriatric surgical assessment team is not optional, it is the standard of care. The volume of older surgical patients seen by specialists at academic institutions creates an experience base that fundamentally changes the quality of risk-benefit communication. Every piece of information presented here exists in published, peer-reviewed literature. The gap is not in the science. The gap is in the translation of that science into the pre-surgical conversation, and that is precisely the gap this channel exists to close. Before closing, if this presentation gave you a framework you did not have before, share it with one person navigating a surgical recommendation right now. The information here does not replace a physician's guidance, but it gives any patient the language to ask better questions and the evidence to expect better answers. If you have not yet subscribed to the Eternal Vigor Way, subscribe now and enable notifications. The research published here next week addresses a topic that affects the majority of adults over 65, and that is almost never discussed with appropriate precision before it becomes a clinical crisis. You will want to have seen it. 3 mechanisms drive the disproportionate surgical risk documented in older adults. First, the inflammatory response to surgical trauma operates differently in aging tissue, with slower resolution, greater cognitive impact, and higher secondary complication rates. Second, the landmark trials underpinning most surgical standards enrolled populations younger and physiologically different from the patients now receiving those same recommendations. Third, for each of the 5 procedures examined today, the evidence base now supports a structured non-surgical protocol as a first-line intervention, not a last resort. The most important thing any older adult can bring to a surgical consultation is not anxiety, and it is not deference. It is a specific set of evidence-based questions that place the burden of proof exactly where it belongs, on the intervention being proposed. For these procedures enrolled predominantly younger, healthier adults. The average age of participants in foundational surgical trials conducted in the 1980s and 1990s was often under 55. Those results were then generalized to patients 20 years older, patients with different inflammatory baselines, different hormonal environments, different mitochondrial reserve capacity, and profoundly different recovery trajectories. Different mitochondrial reserve capacity and profoundly different recovery trajectories. By as much as 15 to 20 years in adults over 65, and that physiological age is a far stronger predictor of surgical outcomes than birth year alone, because the problem is not surgery itself. The problem is surgical recommendations made without adequately accounting, and in the majority of older men, does not progress to lethal disease within a clinically meaningful time frame. Followed over 1,600 men diagnosed with localized prostate cancer for 15 years. Published in the New England Journal of Medicine in 2016 with updated data in 2023, men with low-risk Gleason score 6 prostate cancer who chose active surveillance had equivalent prostate cancer-specific mortality rates to those who underwent radical prostatectomy or radiation therapy. Low-grade prostate cancer is characterized by slow androgen receptor signaling, low cellular mitotic activity. These are permanent, quality-of-life defining consequences, and they carry their own downstream biological costs, including psychological stress-induced cortisol elevation, sleep disruption, and social withdrawal, all of which have measurable effects on immune function and cardiovascular health in older adults. Allows the progression to be detected immediately if biological behavior changes while sparing the majority of patients from unnecessary intervention. That urgency is human and understandable. It is also, in this specific biological context, potentially more dangerous than the cancer itself. It eliminates cardiopulmonary bypass exposure, which triggers a systemic inflammatory response mediated by complement activation and neutrophil degranulation, and it reduces recovery time from 3 to 6 months to 2 to 4 weeks, preserving muscle mass and functional independence during the critical post-intervention period. When discovered incidentally, on an imaging scan conducted for an unrelated reason or during a routine physical examination, with no associated pain, discomfort, or functional limitation, the standard of care has historically defaulted toward elective surgical repair. Specifically, no increased rate of hernia incarceration or strangulation compared to immediate repair. Quality of life scores were equivalent between groups through the duration of follow-up. Diverticulitis, inflammation of small mucosal outpouchings in the colon wall driven by microbial dysbiosis and localized immune activation, affects roughly 35% of adults over 60. Spinal fusion is the surgical joining of 2 or more vertebrae. Aortic stenosis, the progressive calcification and narrowing of the aortic valve, affects approximately 3% of adults over 75. For decades, open-heart surgery requiring full sternotomy and cardiopulmonary bypass was the only available intervention. For the majority of patients over 70 in 2024, it is. An inguinal hernia develops when abdominal tissue, typically a portion of the intestine or fatty tissue, protrudes through a weakened area of the abdominal wall in the groin region. A prospective study published in the Annals of Surgery in 2006, with long-term follow-up data extending to 7 years, found that watchful waiting in men with minimally symptomatic inguinal hernias produced no increased risk of acute complications. General anesthesia in this population has been linked to postoperative neurocognitive disorder in multiple cohort studies, with incidence rates between 20 and 40% at 1 week post-procedure. What distinguishes it is the synthesis, the application of this evidence specifically to the physiological context of aging. That is exactly what the next section delivers. Following 2 or more episodes resolved with antibiotics, elective surgical removal of the affected colon segment has historically been recommended as prevention. The direct trial, published in JAMA Internal Medicine in 2017, examined this recommendation rigorously. Over 5 years of follow-up, elective sigmoid resection after recurrent uncomplicated diverticulitis produced no statistically significant improvement in quality of life compared to conservative management with dietary modification and antibiotic protocols. Every piece of information presented here exists in published peer-reviewed literature. The gap is not in the science. The gap is in the translation of that science into the pre-surgical conversation, and that is precisely the gap this channel exists to close. Before closing, if this presentation gave you a framework you did not have before, share it with one person navigating a surgical recommendation right now. The information here does not replace a physician's guidance, but it gives any patient the language to ask better questions and the evidence to expect better answers.